Good afternoon. I, Dr. Sriram Joshi, Secretary GPA Pune, welcomes all welcome all for today's lecture given by well-known orthopedic surgeon Dr. Neeraj Adkar of Sai Sri Hospital. His topic is clinical diagnosis in joint pains and robotic surgical imitation. Now I request GPA President Dr. Rupa Agarwal to say few words.
Thank you, sir. Good evening, friends. Like every Tuesday and Friday, this week we have a scientific session with Sai Sri Hospital, and we all know Dr. Neeraj Adkar since I guess I know him. I know sir from the time when I started my practice because of my teacher, Dr. Prakash Mahajan sir, and since then we have many times we have got this opportunity to learn various orthopedic related topics from Adkar sir, and it has always been a pleasure and a learning treat to have sir as a teacher, as a speaker. And today again, when during this COVID era, COVID, not just during the actual COVID infection and hospitalization, but even post COVID, the myalgia, the joint pain, so with all various maybe inflammatory or infective diseases, but the joint pain is something which people are always suffering from. And I guess an eminent speaker like Dr. Neeraj Adkar, there is nobody else who can guide us better in this. So without any further delay, I request Secretary to introduce convener and to start with the program.
Thank you, Rupa ma'am. Now I introduce today's convener is Dr. Rajashree Kakade. She had done BHMS, PG, EMS, running her own hospital, Shraddha Nursing Home, since last 18 years. Her hobbies are swimming, Kathak, badminton, Rangoli art and reading. Now I request Dr. Rajashree Kakade to take a charge for further proceeding. Thank you.
Good afternoon, dear friends. It's really my privilege here to chairing this session. Here, I would like today to introduce an eminent personality, Dr. Neeraj Adkar sir. Dr. Neeraj sir has done DMB and D ortho. He has got fellowship in he has done orthoscopy at Spain and training in computer-assisted joint replacement surgery at Melbourne, Australia. He is medical director of Sai Sri Orthopedic Super Speciality and joint replacement.
Sir is medical director of Sai Sri Orthopedic Super Speciality and Joint Replacement Center at Town, Pune. He is consultant joint replacement and orthoscopy surgeon at Pune, Sahyadri Hospital and Ruby Hall Clinic. His special interests are orthoscopy and orthoplasty. His papers published are Imperfecta, a family. Second, total knee replacement using wedge and long tibial stem in severe varus deformity. His total knee replacement using all polytibia. And also brachial plexus palsy due to hematoma formation in hemophilic patients massicon. Also, so many papers are there actually, but here I am introducing some of them. Okay, now I will hand over the charge to Dr. Adkar sir. Thank you, sir.
Thank you, ma'am. At the outset, I would like to thank GPA for giving us this opportunity. President Dr. Rupa Agarwal, madam. Secretaries Dr. Sriram Joshi, sir, Dr. Santosh Kedkar, sir. Convener for today's webinar, Dr. Rajashree Kakade, all the respected members of GPA. Before I start my presentation, I'd like to introduce Dr. Ruben George. He's a physiotherapist associated with the Sai Sri Physiotherapy and Sports Medicine Center. And he's a very well enthusiastic, you can say, and academically oriented physiotherapist. Happy to have you, Ruben, in this webinar. And I'd like to share my screen now. And Okay, so today's presentation will be regarding knee and hip disorders, and I'm given probably today's session will be till I think 5 o'clock, I believe. So I'll finish. I have 30 minutes with me. So this presentation I have divided into three sections. Pediatric knee injuries, which are not that uncommon. More and more children are participating in sports, and they're all high risk sports, and we are getting routinely now very severe injuries in kids. Geriatric knee issues like arthritis and the treatment options and various other elements, and adult hip issues. So brain, as all of us know, knee joint is made up of femorotibial joint and patellofemoral joint. So clinically, we should be in a position to diagnose whether patient is having patellofemoral issue or femorotibial issue. And so clinical diagnosis is very important. Coming to pediatric knee injuries, in US alone, 25 million kids participate in school sports, and another 20 million are active in community-based sports activities. So you can imagine what would be the number in India. And there are around 2.5 million sports-related injuries in adolescents. Knee injuries account for around 60%. So knee joint is one of the most commonly injured joint in any sports. And it is not just in professional athletes, but in recreational athletes as well. When we are treating any child with knee injury, we should not forget basic things. So first and foremost, children are not miniature adults. Okay, and we should remember, whenever we are planning any treatment for pediatric knee injury, the most of the growth in lower limb occurs around knee joint. So physis or growth plate in distal end of the femur and upper end of the tibia is very important, because most of the limb length is going to happen in that area. And physis is the weakest part of the bone, and male female athletes, there are different issues. So pediatric knee injuries, typically it could be acute or overuse. I mean, so मुलगा चालता चालता मी खेळताना पडला, पाय ट्विस्ट झाला, and so there's a acute injury, overuse, or so it could be a ligament injury, it could be a muscle injury, it could be a meniscus injury. And repetitive use injuries, if there is no actual any particular episode of trauma, but kid presents with anterior knee pain, front of the knee joint there is pain, and there is no history of injury, it could be Osgood Schlatter. We are going to go through all these conditions one by one. So clinical examination, again I will insist here, that is very important for diagnosis. Whenever a kid or any patient presents to you, clinical examination. So picture on your left, the knee joint shows bruise on the medial aspect of the knee joint. So this patient will have injury to the medial structures like medial collateral ligament or medial meniscus or medial capsular injury. The picture in the bottom shows the right knee joint, there is posterior sag, it has gone back. So in such cases, there is always a possibility of posterior cruciate ligament injury, PCL, because that's why the knee joint goes back. Otherwise, it will, femur and tibia are in same plane, but as soon as PCL is injured, it goes back. And the drawer test, the video we saw, so as you can see in this video, there is definite laxity of the joint, and because of the ACL, the tibia has not gone back, but it is coming excessively forward. It is seen in ACL injuries, anterior cruciate ligament injuries. So clinically, it is easy to differentiate between whether ACL is injured or PCL is injured. Okay. So again, there is a rotatory. So the foot on the left leg is externally rotated more than the right. It suggests the posterolateral corner injury. So these are various tests with which you can diagnose which structure is injured. So MRI is commonly performed investigation, but X-ray also gives you enough information to diagnose which structure is involved. The slide, the picture on the top left, the arrow is marked, the picture number 1A, which there is a small, flicker of bone. This is avulsion of the capsule, and typically all such cases, this is called a Segond's injury. Typically, all such cases, ACL is injured. Okay, and the picture below that, knee joint is opening out laterally. That suggests injury to the lateral structures. Okay, so these MRI, see, people will always say, why you are going for MRI? But MRI is a very, why you are going for X-ray? X-ray is very cheap investigation, and that will give you fair clinical examination plus X-ray will give you a fair idea how that knee is going to be, and that diagnosis becomes very easy when you have further investigation in your hand. Like X-ray, we can have stress X-rays or under anesthesia examination and under anesthesia X-ray with sedation. Here the joint, the routine X-ray is normal, the bottom X-ray. But when you give stress, the joint is opening out laterally. That means there is injury to the lateral structure. So all these X-ray investigations are important. They are extremely helpful, and one should not ignore this. Apophysitis, or is called as injury to the growth plate and epiphysis region, and is typically seen in around knee joint or in olecranon, and it is more commonly seen in tibial tuberosity. So whenever an adolescent girl or boy presents with knee pain, there is no history of severe knee trauma, repetitive, hyperactive kid, active in sports, and then tenderness will be on tibial tuberosity, not at the joint line. Let me just show you. So this is knee joint model. So tenderness will not be at the joint line, but it will be at the tibial tuberosity, and that's how you can diagnose. Typically, the tenderness will be at the tuberosity, and knee joint movements will be pain-free. And but extreme knee flexion could be painful in such cases. And only thing you need is just splint the leg straight in extension, and it heals in 3 to 4 weeks. Very, very rarely surgical intervention is required. Physiotherapy again plays a crucial role in this condition, and this can be, as I said, with medicines and physio ice fomentation. Patellofemoral pain is difficult to diagnose. There are various conditions which will present with anterior knee pain. So when I say patellofemoral pain, pain will be in front of the knee, not at the joint level. And when you glide the patella, when you move the patella, there will be a pain. Patient will feel the pain. And so these are the chronic cases. And is a huge topic in itself and difficult to cover in this short duration. But at general practice level, you may get patients with acute patella dislocation. As you can see in this X-ray, patella is lying outside on the lateral aspect. So in this case, patella has gone like this out. Okay. So under anesthesia or sometimes in casualty only, we can reduce that. But if there is recurrent patella dislocation, then there are various reasons why a patient will develop recurrent dislocation, and then we need to treat the root cause. Okay, so this is how a patient will present. The patella will be lying outside, not in the center of the joint, and there'll be movements will be extremely painful. There'll be swelling, and we need to reduce that patella. But many times when patella goes out, the underlying cartilage of the patella gets damaged. The cartilage gets damaged, and we need to have MRI, and MRI will often show cartilage flakes or small fragments in the joint. If we just go for X-ray in such cases, you are going to miss cartilage fragments, and they act as a loose body, which can give rise to locking and persistent pain. So MRI is a must whenever there is a case of patella dislocation, especially in recurrent dislocation cases. So again, recurrent dislocation we can discuss at length, but recurrent dislocation usually is because of the trochlear dysplasia. Trochlea is this trochlear groove dysplasia, or there could be issues in the hip joint, and it's beyond scope of this presentation. So coming to meniscus now, meniscus, as all of us know, is chondroprotective. It protects articular cartilage. So whenever possible, save the meniscus, okay? You should not take it out. And it helps in proper joint lubrication. As all of us know, meniscus is divided into 3 zones: the red-red zone, red-white zone, and white-white zone. Red-red zone, as name suggests, it is full of blood supply, rich blood supply, and all lesions in red zone, they usually heal very well. White zone, because of they're devoid of blood supply, healing potential is poor. So whenever there is injury to the meniscus, as I said earlier, we should repair it. As you can see, whenever there is injury, it gets displaced in the center of the joint, and it gives locking sensation. And we should, when we put it back in place, we repair it. That locking sensation goes off. This can be done arthroscopically through 5mm portal, and where just 24 hours hospitalization is required. Very next day, knee movements are allowed. And friends, we should remember that all these meniscus patients, they will present with twisting injury, locking. Typically, मांडी घालून बसलं की सरळ करायला त्रास होतो. Or all of a sudden they will get locking sensation. But X-ray would be normal. It is a soft tissue. So don't hesitate when if person gives you history of locking, recurrent instability, and then effusion, swellings, सूज येत जात राहते. Don't hesitate to call for or go for MRI. And as I said, all these meniscus we repair arthroscopically and through these devices, and absolutely fantastic results. And when we protect the meniscus, it gives you good long-term outcome. We can protect the cartilage, it prevents osteoarthritis. So our aim should be save the meniscus wherever possible. Discoid meniscus is seen in pediatric age group, okay? Typically kid. This is video of a 6-year-old kid, 6-year-old. He presented with audible click of the knee joint. Whenever he was flexing and extending the joint, there was audible pop, and then there was pain, and we diagnosed this on MRI. And then we did not have option but to trim this meniscus. And when we trimmed it, just his pain and symptom just vanished, and he was extremely happy, and he's doing well. Osteochondral defects. So osteochondral means cartilage defects. So any injury can lead to cartilage injury with underlying bone injury. So clinically there will be pain, tenderness, joint movements will be painful, and there will be swelling. So history taking is very important. And such fragments, if there is history of repetitive injury, then there could be loose body in the joint with a cartilage fragment, which will present like this on X-ray. And MRI is must in such cases. And if the fragment is stable, it is not detached from the parent bone, we can treat it with splinting, non-weight bearing, conservative, repetitive X-ray. And if it heals, then obviously it can be successfully treated with non-operatively. But if it gets displaced and it is not a stable fragment, then it needs some operative intervention like arthroscopy and or a cartilage grafting like this. Coming to ACL, anterior cruciate ligament. Okay, so we have already seen the drawer test is positive in ACL, the anterior drawer for ACL and posterior drawer for PCL. And there are 2 bundles, anteromedial and posterolateral. Need not go into detail, but the typical ACL injury will happen in athletes, in sports persons involved in contact sports, and so there will be twisting of the joint, and then it leads to ACL injury. And as you can see in this picture, see, clinical examination is must, but at the same time, MRI will give you information. And as you can see in this MR picture, the picture on the left is normal, healthy ACL. Picture on the right is torn ACL. It is a is a wavy, and there is a bright signal. Bright signal on MRI suggests fluid in that region. And because of the injury, fibers are not intact, and there will be fluid, synovial fluid in those fibers, and it appears bright on MRI. And so that really confirms the diagnosis. This is how the torn ACL looks like during arthroscopy. And in pediatric age group, if kid is not in high-end sports or not involved in very high-end activities, we offer them conservative option till skeletal maturity, because whenever we treat ACL in kids, we have to go through the physis, that is growth plate, and it may affect the growth of the kid, and which may lead to limb length discrepancies. So we have done sufficient pediatric ACLs, but those are growth plate sparing ACLs, and where we don't treat, where we don't touch the growth plate, and otherwise such catastrophe it can lead to. ACL consideration, as you can see in this chart, the Tanner stage is for how much growth is remaining in the kid. That will give you information regarding that. So Tanner stage 4, 5, you are safe, but stage 1, stage 2, better to delay any intervention. So if you are opting for non-operative, go for bracing, physio, icing, medicine, activity restriction. But operative, as you can see in this X-ray, we have not perforated the growth plate here on the femoral side, endo button, and it is done under Siam control, where we avoid injury to growth plate. This is a useful chart, but beyond scope of this presentation. So typically ACL is done after 2 to 3 weeks of initial injury, and both bone patella tendon bone or semity, that is hamstring grafts are used, and there are positives and negatives, advantages and disadvantages of both the graft options, but again, which will beyond scope of this presentation. ACL nowadays we do anatomical way. Anatomical is best way, currently recommended. So, and that gives fantastic results, good rotational stability after the operation, and speedy recovery. So whenever we plan ACL, a small video diagnostic round, as you can see, ACL is completely torn in this patient, and once diagnostic round is over, to confirm that there are no other injuries. And so friends, a point I would like to highlight here: don't rely on MRI blindly. MRI is just 60 to 70% specific. It is not 100%. It has to be correlated clinically. And once the diagnostic round is over, so just to continue that point, previous point regarding MRI I was highlighting, I'm not doubting skills of our radiology colleague, but sometimes ACL, they have mentioned sprain, and when we go in, it is a complete tear. Or partial injury, we go in and the ACL is completely healthy. And so meniscus injury is not reported, and when we go inside, we see complete meniscus injury. So arthroscopy not only helps us to confirm the diagnosis, but at the same time treat it. So this is how ACL graft is pulled in once the tunnels are, and this is semitendinosus and gracilis graft. So hamstring graft is pulled in from the femoral to tibial to femoral tunnel, and we recommend immediate, within 24 hours patient goes home, next day knee movements are allowed, and first 4 to 6 weeks physiotherapy is very important, which Dr. Ruben is going to highlight during his presentation. The tibial imminence fracture is definitely a different issue altogether, and especially in kids, we should be extremely careful, because the growth plate is just underlying the tibial imminence. And this is our own patient where we treated this with a small screws, and as you can see, we have avoided the growth plate. This is important. this we had treated 7-8 years back, and that kid is doing extremely well. Multi-ligament injuries. If patient with road traffic accident comes to you with gross instability of the knee joint, and on X-ray there is no fracture, but the knee joint is just opening out, you as a primary care physician should be extremely watchful for regarding these patients. And because a patient like this, the knee dislocation, there is no fracture, but all ligaments are injured, knee dislocation patient. So such patients, they are likely to have vascular injury. And on day one, Doppler would be normal. You may feel some pulse, dorsalis, pedis, and posterior tibial. And you take him inside theater, you do excellent job, and third, fourth day, it leads to popliteal artery thrombosis because of the internal damage. And then complete blame is on you because you have performed the surgery and it has led to popliteal artery thrombosis. The only way to diagnose such issues, such cases, or rule out any vascular injury is through angiography, peripheral angiography. That will give you information regarding whether that person is having any vascular injury. Okay, so as far as pediatric knee injuries are concerned, we should remember children are not miniature adults. 5 is extremely important. Stage of development, as we discussed, Tanner 4-5 stage, okay, we can safely treat them as an adults, and then it is advisable to go ahead with surgery if indicated. And any kid presenting to you with recurrent effusion swelling, or for that matter any adult also, so don't ignore. And we should be watchful towards referred pain, especially pain on the back side of the knee, or anteromedial aspect of the knee, or lower end of the thigh, lower portion of the thigh. It could be from the hip joint. Back side of the knee, any knee pathology would usually not present with posterior knee pain. So that backside knee pain could be from spine. So clinical examination is important in such cases. Now coming to geriatric knee injuries. So articular cartilage is a special layer, as all of us know. And once it goes off, bone starts rubbing against each other. And this process is called as osteoarthritis. So healthy knee cartilage is not visible. You see gap between two bones. But when the cartilage goes off, bone starts rubbing against each other, and the gap is obliterated on the X-ray on the right side. And this is how typically patient will present with varus deformities. And early OA we can treat with PRP, platelet rich plasma, where it just slows down the process of osteoarthritis and may help us in delaying any surgical intervention if required. But this is indicated in early OA, not in advanced cases. When one compartment is involved, partial knee replacement can be done. So X-ray on your left is partial knee, X-ray on your right is total knee replacement. And so this is done robotically now at Sai Shri. So just affected portion is morphed. So here, I will rather pause this video here. Here I am able to literally play. I mean, with the placement. If I post, so the color, pink color you see here, that much cartilage we are supposed to take out. When it is taken out completely, that it appears white. That's where we stop it. So this is an intelligent assistant inside the theater, and I'm just, so this is how it looks like. This is how it looks like after replacing the partial knee. If the deformity is more, then we need to have wedges and stem. And this is how that person was walking before surgery, and same patient walking after surgery. So the complete deformity correction is possible in knee replacement. It not just changes the joint, but the complete life of the patient. This is pre-op X-ray, post-op X-ray. pre-op gait, post-op, same patient. Mobile bearing TKR, where the insert moves inside and it gives near normal feel to the patient and gives good range of movement post-operatively. 80-year-old gentleman, minimal deformity. That is one of the criteria for mobile bearing. And this is the range of movement of that patient next day after the procedure. That is day 1 post-op. And same patient 12th or 14th day after the surgery. High flex knees designs are available, which gives good range of movement. Happy to share with you colleagues that Sai Shri is the first hospital in India to do same sitting bilateral uncemented TKR. We did this 2 years back, patient from Kothurud, and she's doing extremely well. This lady, a doctor herself, she's a BHMS doctor, senior doctor. Her husband is also a doctor from Ahmednagar, and she successfully completed Narmada Parikrama after both knee replacement. And this is how robotic TKR is done. We'll just run through this video quickly. So like partial knee, here complete knee is mount, and then we can adjust the implant, rotation, same thing can be seen. So this is how it looks like after taking out. And so this is in short regarding robotic TKR. This patient came from Kenya, and she had earlier deep vein thrombosis, refused surgery at many places. And same patient day 2 after the surgery and day 15 after the surgery. Patient from Mawal, before operation and after operation, same patient. Again, bilateral knee pain, severe knee pain she had, and same lady 3 weeks, 4 weeks after the operation. She is doing well. Case of rheumatoid arthritis before and after operation. Relatively young patient. And then this lady, varus deformity. Look at this. This deformity is called as side sweep deformity. So this lady had on one leg valgus deformity. Knee has gone outward, and one side it is a varus deformity. And this is how she used to walk for many years. And same lady after the operation. We are doing through subvastus approach, where we don't cut the quadriceps muscle. Patient came for suture removal on day 5, doing extremely well. And so we'll just skip this couple of videos. This patient at the time of 15th, 20th day after the operation, and he was able to climb the stairs. We'll just skip this. And our own GPA member's mother, and severe deformity. And this is how, this is before operation, and this is after operation. Another patient before operation and after operation, severe varus deformity, and complete correction was achieved. And this is just 15-20 days after the operation. She is able to walk without support now and leading a normal life. So not only just primary joints, we are dealing with revision also. This lady was operated somewhere else. She had a fall and she was treated conservatively somewhere else. The fracture of the upper end of the tibia after replacement, after knee replacement. I hope you can see that, upper tibia fracture, and the tibial base plate was revised like this. This is where, this was unique case because opposite side knee was completely fused. So she was just walking on this leg. And this was a precious knee for her. And same lady walking and leading a normal life. Her right knee is fused, and now left knee she's leading a normal life. Another patient operated somewhere else, a TKR with femur fracture and got infected. We removed that and revised it completely with revision processes, and she's doing well. So coming to last session of my presentation, hip joint. Quickly, I'll run through. Mainly we see avascular necrosis cases, and where we can treat with core decompression or sometimes they need hip replacement. Ceramic on ceramic hip replacement is preferred. This patient bilateral THR was done with large femoral head. Large femoral head gives, as you can see in this picture, good range of movement. He was completely bedridden after before the procedure, and this is how he is doing before after the operation. Just 4 or 5 weeks after the operation, he has undergone both hip replacement and leading a completely normal life. So large femoral head hip replacements are extremely useful, especially in younger age group, where you can get a near normal feel after the operation. This video you must have seen, some of you must have seen before operation, and same patient riding a motorbike after the operation, after both hip replacement. This patient came from Ethiopia, and this is how he used to walk before operation, and just 15 days after the operation, and he went back to his country happily. Various failed fracture fixation cases we are treating, and with hip replacement, this poor fellow was bedridden for nearly 2 years because that screw was protruding inside the pelvic cavity, as you can see in this X-ray, and this was revised and leading a normal life. We'll just skip this couple of X-ray picture, but before I conclude, I would just like to share with you last and very interesting case. Some of you must have seen this. This lady was operated at Mumbai, and this is how she presented to us, but kindly just look at her age, 100 years old, and the screw was protruding inside the hip joint. This is after hip replacement, and this is just 3 weeks after the hip replacement, and today she's celebrating, this year she celebrated her 103rd birthday, and she is doing extremely well. So friends, thank you very much for your patient hearing. I hope I was able to raise to your expectations, and before Ruben starts sharing his screen, I'll be happy to answer any questions if you have. Thank you very much.
Dr. Neeraj sir, we have a question here. If you can click on question answer box, you'll be able to see.
So both PKR, both knees, what are the charges? I mean, this is a difficult question to answer during the webinar. I hope everyone will agree with me, but lot depends on what type of implant we are using, and because the implant cost varies from say 35,000 rupees to a lakh rupees, and a lot depends on the preoperative deformity and the osteoporosis and age, and patient's expectations post surgery. So patient is going to be super active, then we need to have implant which will last long. Implant in a 55-year-old gentleman and implant in a 75-year-old gentleman, obviously there is going to be some difference. So I'll be happy to answer your question in person. If you are, maybe you can share the X-rays and then we can discuss. Thank you.
To ask one question, sir. In between lecture, you have explained us about some stem cells therapy, which will going to heal. Can you explain some little about it?
Just give me a minute, please. Okay. So I have stopped sharing my screen, and maybe Ruben can start sharing. The question was regarding
stem cell therapy.
Yes, early osteoarthritis, or in sports injuries also, we use this platelet-rich plasma. So patient's own blood we centrifuge, and we take out the platelets and then we inject them inside knee joint. So all of us know platelet has got tremendous healing potential, and they can get transformed into any cell, and that is how it helps in osteoarthritis to a certain extent, regenerate the cartilage, and in sports injuries it helps in speedy recovery. But the only precaution all of us, I mean, as a treating physician, we need to take that whenever we use PRP, we should not give painkillers for at least 72 hours, because all NSAIDs, they inhibit the platelets, and then action will get just diminished. So we should take that precaution. Okay, maybe I'll just answer one of them.
Sure.
And the recurrent effusion, knee effusion, managed conservatively, or does it need invasive treatment? See, effusion is the presenting symptom. So we should know why that effusion is there, whether it is infective, whether it is because of any type of arthritis, or whether it is because of any injury, underlying injury. So diagnose that condition, treat that condition, automatically effusion will go down. It could be because of osteoarthritis, it could be because of rheumatoid arthritis, could be because of any injury to the structure like meniscus, ligament we discussed during our presentation. The types of implants in the TKR. So we have cobalt chrome implants, we have implants which are coated with titanium niobium nitride, we have implants called oxynium implants. If the deformity is more, we can use wedges and the stems, long stem for additional stability. And so these are all unconstrained implants. We have with severe deformity, semi-constrained implant. When the collateral ligament, medial and collateral ligaments are injured, then we have constrained implant or rotating hinge implant. And so the whole spectrum is there. And as I said earlier, the hinge implant would cost you around 3.5 lakh rupees, or sometimes more than that. And the baseline implant could be 35,000 rupees or 55,000 rupees. So based on the deformity, injury, osteoporosis, we decide the implant. And the last thing, precautions for healthy knee at menopausal age. And so precautions, prevention is better than cure. Regular exercise. If you are having knee pain, better to get it checked and rule out any serious injury. If you don't have any knee pain, then knee strengthening exercises, which Dr. Ruben is going to highlight and is going to present. Quadriceps is a workhorse for knee joint, and you need to have good strength in your quadriceps to prevent osteoarthritis, to prevent any injury. See, injuries are very common in recreational athletes than in professionals, because professionals, they have good muscle strength. Recreationals, we call them weekend athletes. Weekend ko badminton khelna, tennis khelna, and then you injure your joints, shoulder, knee. So because muscle strength is not good and you indulge in all these activities, you are likely to injure your joints more than the professional athletes. So muscle strength, quadriceps muscle strength is extremely important, which is going to help you to prevent any injury and prevention of osteoarthritis. I think over to you, Ruben, now. We are already running late.
First of all, I'd like to thank the GPA and also Dr. Neeraj Adkar sir for giving me the opportunity to present my inputs as to tell everyone how important it is, not just the surgery, but also the post surgical intervention rehabilitation part, so that a patient can come back to a normal functional life. So I shall be talking about mainly the main operations which take place, which includes a total knee replacement, a total hip replacement, as well as ACL and meniscal injuries. And I shall be covering what are the most important points, what we physios and also caretakers or the family members of the patient should know, so that there is no risk of re-injury, so that a patient does not come back with any sort of problem which may kind of put a burden on their lifestyle as they grow older. So I'd like to start first by, I'd share the screen. So I'd start from the TKR and THR. Now the total knee replacement as compared to the total hip replacement has comparatively a lesser amount of risks compared to the total knee. When a patient comes to us with a total knee replacement, a very major advantage knee patients have is that they can start weight bearing on the first day itself. Now, the problem with a THR patient is that complete weight bearing is not possible immediately on the first day, because the replaced joint needs some time to consolidate, and which is why we wait for around 5 to 6 weeks before weight bearing is started on that particular joint of the affected knee, of the affected hip, I'm sorry. So there are certain precautions which we physios need to take and also others need to care about, which includes the one I have given on the screen. First is to avoid hip flexion greater than 90 degrees. The reason why we do this is because a replaced hip is placed slightly laterally, and any sort of movements as given here, for example, adduction more than neutral, going into, or any sort of rotation, it causes the head of the femur to slip out of the acetabulum, and we need to avoid this risk, which is why any sort of rotations or any sort of adduction movement, or even for that matter resisted exercises in the outward side, that is abduction, is also avoided to a very large extent. And for this we need to make sure that a patient is being taught as to, he should be known, he should be given the information regarding what needs to be done when he's on bed, because for a lot of time mobility is affected, he needs to use an assistive device for around 6 weeks, so it becomes a little difficult for the patient to manage. So the exercises per se is to maintain the strength which has already been affected in that group. As sir had mentioned before, the quadriceps and the hamstrings, two major muscle groups which work the joints, and this could be same for both the TKR and the THR. The protocols which we follow in Sai Shri Hospital is kind of the same apart from the weight bearing schedule. And I'd like to show the video which shows basic static strengthening exercises. Now these exercises are only isometric, which means basically that there is no change in the length of the muscle. Why this helps the bedridden patients is it helps them in stimulating the strength in the muscle which is not there post surgery. There's always a guaranteed loss of strength post surgery, and the reason for giving these exercises is that it helps in uh, regaining that strength so that they are able to start on a weight bearing pattern. So I shall be showing this video. I hope it's visible to everyone. So this is the static hamstring strengthening exercise. Basically what is done is placing a towel roll or a pillow under the ankle of the patient. A patient is asked to contract the hamstring muscle. Basically that can be done by asking the patient to press the heels down on the ground. This is usually started in a way so that basic strength is maintained in a patient post surgery. We usually repeat this over a period of time, and we ask them to repeat this exercise almost 10 times each time they practice this exercise, once in the morning, once in the afternoon, and once in the evening. This by research has been noted to have given the best results, and which is why we implement this in almost all our protocols. Another example would be uh, VMO strengthening. So one important thing what I needed to tell about the VMO, that is the vastus medialis obliquus. It's one of the most important muscles of the knee joint, especially after TKR. It undergoes a lot of loss in strength. And the reason why I'm emphasizing on the VMO is because any sort of weakness in the VMO causes the opposite group of the muscle, that is the tensor fascia lata, to push or pull ideally the patella to the lateral side, which causes a lot of tightness in that muscle. So post surgery, when patients do not perform their exercises effectively, a pulled patella to the lateral side causes tightness of the tensor fascia lata, and that in as a cycle even more weakens the vastus medialis obliquus. So for some patients, they may uh, experience something called as an apparent limb lengthening, where they feel that the operated side is a little less in length compared to the non-operated side. Even though it's not true, it's an apparent lengthening where they only experience. So for that, strengthening of the vastus medialis muscle is extremely important, and this is the way we do it. It's basically done in 3 ways. So we place a towel roll under the knee, where we basically ask the patient to contract his knee, pull his knee inward so that the strength, that is how the the fibers of the vastus medialis are most contracted in that particular position. And we can slightly progress by asking the patient to raise his knee from that particular position. As shown in the video, you can see that he raised his knee. Again, all these exercises are done with a particular amount of hold in them, and there is a final variation which can be done to patients who are a little more greater in their strength compared to the others. It's not easily done by the geriatric patients, but in patients who are comparatively less in age, the last motion would be to externally rotate the leg and then take it up. This completely isolates the vastus medialis muscle and gives the best effect as to when you want to see any strengthening of the vastus medialis obliquus muscle. So basically what we follow are these particular rules, and the reason we consider this important is because the muscle weakness is something which is very easily or very commonly seen in such patients. And when you are trying to explain to a patient the reason as to why they're not able to walk in a proper pattern, or why they're not able to do their functional activities properly, weakness of the muscle plays a very major role in it. So now I'd like to go to the next. This is basically the formality we follow for TKR and THR patients. So now I'd like to share the protocol which we follow in ACL and meniscal injuries. Now, the strengthening protocol, as we see, sir had already talked about the causes and the risk factors as to why ACL and meniscal repairs take place. Now, I would like to emphasize on one particular point which is experienced in majority of the patients. Now, research has shown that almost 60 to 70% patients experience a proprioceptal loss while they have undergone any sort of ACL or meniscal injury. So proprioception is basically a specialized variation of a sensory modality which gives your joint awareness regarding where it is in space. It gives knowledge to the body regarding joint movement and its position. And it's basically, it consists of three components. The first one is static awareness, basically where the joint is located in one position. The second is detection of movement, especially when a patient is walking, any sort of acceleration or deceleration. And the third is a reflex response by the muscle. So these are the three basic components of proprioception, where the strengthening protocol, as I mentioned earlier, remains the same for these patients, although the weight bearing status may be different. We need to remember that when the weight bearing statuses are different for each surgery, we also need to make sure at the same time that that patient is able to maintain strength in the muscle groups which are not been affected as much as the ones in surgery. So it's also
Ruben,
been shown.
Ruben, sorry to interrupt. I mean, for benefit of all the our physician colleagues, so
Okay.
I'd like to highlight here what is proprioception.
Okay.
Maybe till
Yes,
that time you can just start sharing the screen, other screen.
Yes.
Keep it ready. So proprioception. So if you watch say 100 people walking on a road, and if you watch how they are walking, everyone's pattern is different, how they walk, how they move around. So if you're walking and then suddenly suppose there is a footpath, you don't look at the footpath and then you take it up, you take your foot up. Your brain knows where your foot is. Your brain know what is the position of your knee joint, what is position of your hip joint. And at subconscious level, hip is slightly flexed, knee is flexed, and foot, and then you just put and just move ahead. So in simple word, that is proprioception. So the position of your joint, what brain analyzes, and that is very important. Ruben was talking about ACL and meniscus. I mean, that is extremely important in knee joint also. So knee joint, when a patient comes back after say 4 weeks, 6 weeks, So something is different in the joint. That's what they will say, because that proprioception reflex has not yet developed. It takes a couple of months after surgery. And it's in ligament surgeries in young adults, our physio team, they need to take extra efforts for all these reflexes. Maybe you can start sharing your screen, and we have just a couple of minutes more.
Yeah. I'll be quick. So I'll show you the most basic proprioception exercises which we perform. It's as simple as managing yourself on an unstable surface, which helps in kind of giving the joint the perfect awareness it requires. As seen in the video, what she is doing is placed herself on an unstable surface, a movable board, and trying to balance herself in such a way that she does not step out of that movable board. What this helps in is giving that proprioceptive awareness to that joint so that it understands where it is and it is able to react accordingly or reflect accordingly to the needs of that particular person in that plane. So this is why proprioception is extremely important. And another exercise which I would like to add is the one of strengthening the muscles using resistance bands. Now, why resistance bands? I'll not play the video for it because we're running short on time. The reason for why we use resistance bands in ACL or meniscal repairs for earlier rehab is because the composition of the arm, as you see with weights, you can rest it in one particular position. This is a very important classification we need to make in between TKR or any sort of ACL reconstructions. The main thing is weights are used in TKR because they can rest the joint in a particular position. The main advantage of a resistance band is it provides tension throughout the range of motion. So in ACL patients, because they're mostly athletes, as sir had mentioned earlier, they're mostly athletes, and so they need to gain their dynamic strength throughout the range of motion. So for them, resistance activities are extremely important, and that is why we prefer the use of resistance bands over weight in patients with an ACL or a meniscal injury. And in the case of TKR and THR, for strengthening, we mainly use any sort of weight cuff. So this gives the best sort of results. And this is obviously in the acute part. In the rehabilitation part, as we progress over 5 or 6 weeks, we have a very advanced sort of protocol, which is including a dynamic strengthening of all the muscle groups you see. So it will be that includes even the opposite leg or the good leg, so that patient starts balancing himself and can return to sport as easily as possible. For geriatrics, yes, we go a little slow. For them, a proprioception exercise would be as simple as standing on one leg for 10 seconds. That gives them more than enough information so that they are able to manage themselves as they are walking out on the road, where there are a lot of obstacles which they need to face. So that's it. I'd like to conclude my talk by just making people aware that they should know what they are doing to their patient. Simply exercising a certain group of muscle just for the sake of knowledge is not worth it. You should know as to why you are doing it. You should know what you are supposed to expect after a certain period of time. And just by knowing what you want to achieve, by applying certain goals, you can get the best results in the least amount of time. Thank you.
Dr. Adkar sir, for such a nice, wonderful lecture. Your video, whatever you shown, was really amazing. We have get a lot of knowledge regarding to meniscus injuries, orthoscopies, and ACL repairment. And also, you have shown us that robotic surgery. It was really wonderful.
Sir, Dr. Rajeshri, just 1 second. Sir, we have actually 10 minutes time. There are 2-3 questions more, Dr. Adkar. If you allow, will you be answering those questions?
Yes, actually, OPD time already, but I'll try to answer them quickly.
Yes, sir. सर बेसिकली एक प्रश्न असा आहे की एक्सरे नी नॉर्मल पण पेशंट कंटिन्यू टू गेट नी पेन पोस्टेरियरली व्हॉट क्लिनिकल डायग्नोसिस शुड बी सस्पेक्टेड आणि फायनान्शियल कन्स्ट्रेंट आहे त्यामुळे MRI वगैरेचा स्कोप नाही असा एक प्रश्न आहे.
पोस्टिरियर नी पेन आता क्लिनिकली साईन्स काय ते बघायला पाहिजे एक तर पोस्टिरियर नी पेन मग बॅक साइड ऑफ द थायला पण आहे का किंवा बॅक साइड ऑफ नी फक्त असेल तर रेफर्ड पेन नाही ना एकदा रूल आउट करा फ्रॉम द स्पाइन अँड त्याच्यामध्ये एक्सरे नॉर्मल असेल इफ देर इज नो हिस्ट्री ऑफ इंजुरी देन यू कॅन डेफिनेटली ट्राय फिजिओथेरपी फायनान्शियल कन्स्ट्रेंट आता म्हणजे असतील तर बघा तुम्ही मेडिसिन फिजिओ त्यांनी पण नाही झालं तर मग MR इज इंडिकेटेड.
Okay, sir. Thanks. And can recurrent knee effusion be managed conservatively, or does it need invasion
Yes.
treatment?
I answered that question, madam.
Yeah. Okay.
And because we need to treat the root cause of that effusion, not the effusion. Effusion is a symptom. So we need to go to the root cause, whether it is osteoarthritis, rheumatoid, any injury, or infection for that. So we need to treat the root cause. Effusion will automatically settle.
Okay. Thank you, sir. And here is one question for Dr. Rubin. Physiotherapy, if you could just highlight one or two physiotherapy tips for ankle ligament rupture.
Okay, ankle ligament ruptures are actually very commonly seen in especially athletes of who run a lot. So ankle ligament injuries are a little tricky because the ankle joint is extremely complex. So for pain reduction, mainly we offer something called as a contrast bath, as opposed to other joints. When people say my knee is hurting, we usually suggest them an ice pack. However, for the ankle joint, we suggest something called as a contrast bath, which offers alternate treatment between heat fomentation and ice. So what that does is, when it stimulates a reaction called as a Lewis Hunting reaction, and the reason that helps is, particularly for the ankle joint, is it helps in reducing the pain the fastest. That's what research has been told. Now post rupture, when we are doing for the rehab, we kind of talk to the patient and ask what he wants. If a patient is playing a particular sport, we train the patient in that particular sport itself. For example, if a patient is a footballer, he has to do a lot of dribbling action between his foot, which is mainly the action of the ankle. So a lot of ankle activities would be included with the help of a football. We try to replicate the actions which he's trying to do, and the particular muscles associated with those actions are strengthened first. Obviously, I'm talking about the rehab part. Not this does not happen immediately post rupture. This is after the repair has been done or post surgery, or whether it's been conservatively managed. That depends on the surgeon. But I'm talking about the post repair scene, where we totally depend on the outcome of the patient, where the patient has a certain goal and we fulfill it according to his or her needs.
Dr. Rajeshri, over to you.
Thank you, Dr. George, sir, for excellent showing us excellent whatever exercises we have to do after knee replacement surgeries, and also he had deeply elaborated us about hip precaution, what should be taken after hip replacement surgery. So thanks for joining us here and giving us valuable information. Thank you so much.
Thank you. I, Dr. Sriram Doshi, Secretary GPA Pune, grateful to today's speaker, Dr. Neeraj Adkar sir, for such informative and excellent lecture. I also thankful to Dr. Ruben George. We also thankful to today's convener, Dr. Rajeshri Kakade. We sincerely thanks to Dr. Madhuri Zankar ma'am for arranging this lecture. We are also grateful to our technology partner, DigiShield. Last but not least, I sincerely thankful to all delegates for taking out their valuable time. Thanks all. Take care yourself and your family. Thank you all.